Hi class, my name is Ashley Miller and I will be presenting my project, an educational intervention to increase HIV knowledge and decrease HIV incidence. To begin my presentation, I'm going to discuss the burden of this disease and will begin by sharing some background information. This is an important problem that affects many individuals' lives across the world. So, what is HIV? HIV is a virus that is spread through certain body fluids that attacks the body's immune system. Specifically, this virus attacks the body's CD4 cells, which makes it difficult for the body to fight off both infections and diseases. This virus is spread through semen, blood, vaginal and anal fluids, as well as breast milk. It is not transmitted through sweat, saliva, or urine. This is a common disease, as there are approximately 1.1 million people living with HIV in the United States. Surprisingly, 1 out of 7 people do not know they have the disease. For example, there were approximately 37,600 people that were newly infected with HIV in 2014 alone. This is a global issue, and there are many people affected around the world. As you can see from this chart, there are 1.8 million people newly infected in 2016 globally. Fortunately, overall, there has been a decline in the number of new cases of HIV. For example, in 2015, there were 2.1 million new infections of HIV globally. There are still countries that are facing increasing trends, and this is seen in Eastern Europe and Central Asia. However, the global progress that has been made thus far is still not enough to meet the global targets. When discussing the severity of this disease, I will discuss the stages of the disease. An individual's health gets progressively worse as this disease progresses. There are 3 stages of HIV infection that leads to AIDS. The first stage is the acute HIV infection, and this is where people may experience flu-like symptoms. This happens 2 to 4 weeks after infection. However, some individuals may not feel sick at all. In this stage, the individual has a large amount of virus in their blood, therefore, they are highly contagious. The second stage of this disease is the clinical latency stage, otherwise known as the dormancy stage. HIV is reproducing at low levels, and this period can last for years. Some people may progress faster in this stage. As the viral load starts to increase, the patient now enters into the stage 3, which is the AIDS stage. This is the stage where the person now has a damaged immune system and is in danger of infections and other illnesses. This stage is diagnosed when the CD4 cell count drops lower than 200 cells or opportunistic infections are present. This is a preventable disease if people take the appropriate measures. This includes using protection during sex, such as using condoms, limiting partners, not sharing needles, and preventative medicines such as pre-exposure prophylaxis, otherwise known as PrEP. The economic value of HIV prevention in the United States is substantial given the high cost of HIV disease treatment. It was found that an estimated cost for a lifetime of HIV treatment was approximately $379,688. These 3 graphs below show the recent trends of this disease and the population groups that are most affected. As you can see from the figures, gay men and African American men are the most affected by HIV. Figure 1 shows HIV diagnosis via transmission. Males that have sex with other males were infected the most. Figure 4 shows HIV diagnosis among males that have sex with males between the ages of 13 to 24 by race and ethnicity. As you can see, African Americans were the most affected. Figure 5 further shows that African Americans are the most affected. However, this was slowly trending down. Finally, new infections among adults are now estimated to have declined by 11% and 16% for the general population between 2010 and 2016, whereas there was only an 8% decline between 2010 and 2015. Major risk factors for this disease include having unprotected sex, and this includes both anal and vaginal sex, The estimate of per risk act of transmission for vaginal intercourse is 0.1, with a 95% confidence interval of 0.05 to 0.11. For anal intercourse, the estimate of per risk act of transmission for anal intercourse with ejaculation is 1.43, with a 95% confidence interval of 0.48 to 2.85. With withdrawal, it was 0.65, with a 95% confidence interval of 0.15 to 1.53. There has been conflicting evidence found where male circumcision decreases the risk of transmission. Biological factors account for the increased susceptibility for those men that are not circumcised and include internal foreskin being retracted during sex and the susceptibility of tears and abrasions. However, statistical significance was not found. The impact of circumcision for males that have sex with males on the risk of transmission has an odds ratio of 0.86, with a 95% confidence interval of 0.65 to 1.13. Also, sharing contaminated needles and receiving unsafe injections are additional risk factors. HIV transmission probability through injection with contaminated needles is 0.84, with a 95% confidence interval of 0.7 to 1.0. Finally, healthcare workers that are exposed to accidental needle stick injuries is an additional risk factor. Other risk factors include having a different sexually transmitted disease, such as syphilis, herpes, and chlamydia, to mention a few. The outcome of these risk factors leads to HIV, which ultimately leads to AIDS. The specific risk factor that is being targeted for this intervention study is unprotected sex. There has been a large amount of data that shows unprotected sex and the relationship to HIV incidence. HIV is spread by body fluids, such as semen, vaginal, and anal fluids. Therefore, safe sex practices can prevent this disease. The types of studies that have documented the association are both randomized control trials and quasi-experimental designs with independent comparison groups. I will now discuss some intervention studies that have been conducted to target unprotected sex, as it is a risk factor for HIV incidence. A systematic review and meta-analysis was completed by Johnson in 2005 to summarize effects of behavioral HIV prevention interventions and the risk of HIV transmission. The first I'm going to discuss is small group format interventions to teach safe sex in order to prevent HIV. Varying methods were utilized and included lecture on safe sex practices, seminar on sexual education, and safe sex workshops. Individual level format included safe sex videos, as well as counseling and education with written materials. The last educational format utilized was community level interventions. These included outreach as well as small group educational programs, using HIV educational materials, community programs, and intervention programs within different communities. I'm now going to discuss the objective of this study. The overall aim of this study was to develop an HIV educational intervention to increase HIV knowledge and decrease HIV incidence among a group of college students at a local university in northeastern Pennsylvania. Based on the literature review, there is no one specific way to teach HIV education to prevent this disease. There have been a variety of interventions utilized, as discussed in the previous slides. There were some gaps in the literature found, such as limited generalizability of the findings and the date the study took place. For example, there were some studies discussed as early as 1989. Further research in this area is needed to determine superior methods for teaching this content. Moving on, I'm now going to discuss the methodology for the study. This study will be a quantitative randomized control design that is individual-based. Participants will be randomly assigned into either the experimental group or the control group. The intervention group will receive the HIV educational intervention, whereas the control group will receive smoking cessation education. The setting for this study is one university located in northeastern Pennsylvania. The population of interest are traditional first-year college students. The setting and population were chosen for the study because young adults were the fastest growing group of individuals for new HIV infections in Pennsylvania. The college setting was chosen to target the specific population of young adults. This college provides a first-year foundations class for students that focuses on important topics for young adults, so this was an ideal setting for the study because HIV education is important for prevention. The intervention will be delivered in the classroom setting and focus on specific components to educate on this disease, and most importantly, how to prevent this disease by safe sex practices. This program will take approximately 1 hour to complete and will include a PowerPoint presentation, HIV educational handouts, short videos, and groups activities. There are currently 175 eligible first-year college students available for participation, and all will be invited to participate in the study. The outcomes of this study are HIV knowledge, and this will be assessed in the intervention versus control group. Knowledge will be assessed by utilizing a pre-test and post-test that assesses HIV knowledge to determine if there was an increase in knowledge post-educational intervention. A valid and reliable tool was selected to measure HIV knowledge. The post-test will be implemented immediately after the intervention and again at 6 months and 4 years to determine if HIV knowledge was sustained. The second outcome being measured is the incidence of HIV among this group of participants. HIV testing is free at this university, and a complete STD test is encouraged yearly. This will be tracked for 4 years while participants are enrolled. As for anticipated outcomes, I expect to see that the intervention group will have increased HIV knowledge and decreased rates of HIV when compared to the control group. The anticipated time frame for the study is 4 years. The post-test to assess HIV knowledge will be given immediately after the post-test, 6 months later, and 4 years later to determine if knowledge was sustained. HIV incidence will also be tracked each year during the 4-year time frame to determine HIV incidence. Strengths of the study included randomization. Participants will be placed into either the intervention or the control group. An additional strength is the follow-up to assess HIV knowledge to determine if this knowledge was actually sustained. Some limitations to this study do exist and include the generalizability of the results. This study is taking place in one university that is located in a specific area in northeastern Pennsylvania. Results may vary elsewhere, therefore it may be difficult to generalize the findings of the study. Also, there may be attrition with participants due to dropping out, transferring to a different university, etc. It will also be difficult to follow participants after graduation. I'd like to acknowledge the local university for allowing the study to take place. I want to thank you all for listening to my presentation, and I'm happy to answer any questions that you may have. My references are as followed. Thank you.